On this week's episode of Give Us a HD Can, we'll be going over treatments of cancer using the mechanics of immunotherapy checkpoint inhibitors. Before we get into the topic, let's have a look at some background info. Our immune system contains different white blood cells that protect our body. The main leukocyte that we are focusing on today is a T cell referred to as CD8+ or cytotoxic T cells. These T cells are constantly scanning our bodies using the MHC class I complex. Every nucleated cell in our body contains this MHC class I complex. Its main function is to present a fragment of non-self protein on the surface of the cell, essentially like an ID card. If these cells in our body are identified as bad quality, the cytotoxic T cell will then trigger it to undergo apoptosis, essentially killing itself. The CD8+ T cell exocytoses proteins such as porphyrin, which is capable of creating little holes in the membrane of these cells. Another enzyme known as granzyme enters these holes and therefore triggering the mechanism of apoptosis. Cancer can be viewed as a villain that humans have been trying to destroy for a long time. It is the leading cause of deaths in Australia, and as of 2012, more than 43,000 people have died from the hands of this disease. Cancer occurs when a normal cell's gene is mutated, sending out abnormal orders and multiplying uncontrollably, creating a tumour. It becomes very dangerous when these cancer antigens travel through the vessels of the body to other organs and continue proliferation. This is known as metastasis. These mutations can occur from many different factors, whether it ranges from genetic heritage, poor dieting, exposure to toxic agents, viruses, and radiation. Knowing this info about cytotoxic T cells and cancer, we would think, why can't these T cells just kill cancer cells? It's not that simple. Recent studies do show that cytotoxic T cells are identifying these cancer cells, but they are not destroying them. This discovery shows us that multiplying cancer cells do suppress the killing abilities of cytotoxic T cells. Treatments for cancer do exist, and they have proved to cure or control the cancer from spreading further in early stages. Such treatments are chemotherapy, radiotherapy, and surgical removal of the tumour. Since 2010, a newer treatment known as immunotherapy has been recognised. It exploits the properties of cancer cells that suppress the T cell's ability, specifically the surface protein known as PD-L1, which is on the surface of the cancer cell, and CTLA-4, which is on the surface of the T cell. T cells require recognition of the MHC1 complex to verify the identity and the activation of the T cell. This is done when surface proteins B7 and CD28 bind together. By activating the T cell, it allows for destruction of the mutated antigen. However, CTLA-4 grass cuts the CD28 with a higher attraction to the B7. The aftermath of this relationship allows for a downregulation of the T cell's ability to destroy the cancer antigens. Therefore, blocking the CTLA-4 checkpoint is an effective way of upregulating the activity of the T cell in the immune system. Another focus in immunotherapy is the surface protein PD-L1. It is found on mutated cancerous cells which binds to B7.1 and PD-1. The binding of these surface proteins results in the deactivation of T cells and disabling it from releasing porphyrins and granzyme, which can kill tumour cells. The blocking of the PD-1 checkpoint would disable the binding of PD-1 and PD-L1. Therefore, we can continue to kick cancer in the butt. There have been few drugs that have been approved which focus on the blocking of the PD-L1 and the CTLA-4 pathways. 3 of the latest approved drugs are pembrolizumab, nivolumab, and ipilimumab. More like tongue twisters. Ipilimumab, commercially known as Yervoy, was approved by the FDA in March 2011. It is used to treat melanoma patients. It works by preventing the binding of CTLA-4 to B7. This antagonism results in the increasing of the body's immunity to fight off those cancer antigens. The FDA approved this drug based on the survival rates of patients with an efficacy of 3 mg per kilogram intravenously over 90 minutes for 4 doses. Ipilimumab is associated with the following toxicities: dermatologic, neurologic toxicities, hepatotoxicity, endocrinopathy, and enterocolitis. A drug that is used to treat metastatic melanoma patients is pembrolizumab. It was approved by the FDA in September 2014 and it is administered intravenously. Unlike Yervoy, pembrolizumab acts by blocking the PD-1 pathway. The effects of this drug have been described as reversible and easily managed in majority of cases, but overdose does lead to life-threatening issues. An example of these mild to moderate adverse effects are fatigue, nausea, diarrhea, and pruritus. Nivolumab works in a similar fashion as pembrolizumab by blocking the PD-1 pathway, but it also has an effect against the PD-L2 receptor. This then makes it effective against lung cancer, melanoma, and kidney cancer. Nivolumab has similar side effects to pembrolizumab with no serious toxicities. It is reversible and it can be treated in early indication. Even though there are toxicities associated with these drugs, the benefits do outweigh the risks. As good as these drugs might sound, don't test your luck with cancer. That is the time we have for this week. Stay healthy, guys, and remember, slip, slop, slap.